Welcome everybody. As a continuation of OphthoKnight Notes, we are excited to share the next part of this educational series, OphthoKnight Refractive Notes. This volume carries the same purpose, to present complex ophthalmic concepts in a clear, organized, and exam-oriented way designed to guide you step by step with clarity and simplicity. The links are in the description, download it now. But before you start reading, it's recommended to watch this video till the end, as we'll show you a video for each surgical procedure so you can see the operation first and understand its flow before diving into the notes. That way, when you read, everything will make perfect sense. We hope these notes help you learn, revise, and grow with confidence on your ophthalmology journey. Special thanks to all the doctors and educators whose surgical videos have helped spread ophthalmic knowledge worldwide. This content is shared for educational purposes only, with full respect and credit to the original creators. Overview of refractive surgeries. Refractive surgeries are a group of procedures designed to correct visual errors and are broadly classified into three main categories: keratorefractive procedures, lenticular refractive procedures, and combined procedures. Let's begin with keratorefractive surgeries, the most common and diverse group. These procedures work by changing the curvature of the cornea, thereby modifying how light rays are focused on the retina. They can be categorized into 5 principal groups: incisional procedures, surface procedures, intrastromal procedures, corneal implants, corneal shrinkage procedures. Let's now explore each of these in sequence. 1. Incisional procedures. The first of these, radial keratotomy, or RK, is now largely obsolete. In this technique, deep radial incisions were made in the peripheral cornea using a diamond knife. These incisions cause the central cornea to flatten, reducing its refractive power and correcting myopia. Sorry about the quality of the video, but it is the only video available for this procedure. Soon after, hexagonal keratotomy, or HK, was developed to address hyperopia. Instead of radial cuts, hexagon-shaped incisions were made in the mid-peripheral cornea. This caused the central cornea to steepen, thereby increasing its refractive power and improving distance vision for farsighted. I couldn't find any video for this procedure. To treat astigmatism, astigmatic keratotomy, or AK, was introduced. It involves 1 or 2 arcuate incisions made perpendicular to the steep meridian of the cornea. This selective relaxation flattens the steeper axis, while the opposite meridian remains unchanged or slightly steepens, effectively reducing astigmatism.
We instill 3 drops of propertine anesthetic, then place a mark at the 3 and 9 o'clock positions of the limbus while the patient is sitting upright. Then the patient is reclined and positioned under the operating microscope. An eyelid holder is placed to keep the eyelids apart. The patient is then asked to look straight ahead at a fixation line. It has a refraction of minus 0.75 plus 1 at 13. We mark the cornea with an 8mm optical zone marker painted with gentian violet ink. Then we mark the steep axis of astigmatism with an axis marker. Finally, we mark the length of the incisions straddling the steep axis. In this case, 1 diopter flattening is desired. We set our calipers to 2mm and then place the mark straddling the steep axis. A few surgical pearls. Stabilize the eye with 0.12 forceps with teeth to provide countertraction and prevent torque of the eye from the diamond blade. We either move the diamond away or toward the 0.12 forceps with teeth. Also, stabilize the hand with the 600 micron guarded diamond on the patient's face or cheek so that the diamond will move in sync with the patient if the patient moves suddenly. The incision usually takes about 5 to 10 seconds. We usually make 1 pass and then a pass in the opposite direction to make sure the incision is at the full depth of the diamond blade.
Limbal relaxing incisions, or LRIS, became a common adjunct to cataract surgery. In this technique, paired arcuate incisions are made near the limbus along the steep meridian to correct mild to moderate corneal astigmatism without altering the central cornea.
This is Sam Gard from the Gallup Institute at the University of California, Irvine, and in this video I'm going to demonstrate a manual LRI technique. The first step is to use your LRI marker to adjust the length of the desired LRI. Depending on how much astigmatism you're trying to treat, the length will vary. In this step I'm using my fingers to try to set the length and the axis for which I would like my marks to be on the cornea. After marking the marker with a gentian violet pen, I will then place it on the cornea, making sure I use my reference marks to properly place the axis for which the marks will be used. Next, I will use my adjustable diamond blade to place my LRIs. It's important to first press down, let the cornea relax, as you can see here, and then move the LRI blade from one mark to the next, observing the curvature of the limbus. This is then repeated for the other side. There are various ways to achieve this and various blades that are available on the market. It's important to familiarize yourself with the different options that are available. But again, I'm depressing onto the cornea, letting the blade relax, and then traversing from one mark to the other. You can then proceed with your normal thick emulsification technique.
I'm going to demonstrate an LRI now. It is very important to dry the surface of the eye before you mark, otherwise the ink markings can run. So I use a Lexel sponge and I use a Mendez ruler. There are many different ways of marking. One isn't better necessarily than the other. And in this case, I use an inked calibre to mark my 3 dots, my arc that I'm going to connect with a diamond blade that's preset. I go in perpendicular to the cornea and in one gentle move, drag the LRI blade and connect the 3 dots and then remove, and the LRI is done.
A related concept is the opposite clear corneal incision, or OCCI. Here, after the main cataract incision is made on the steep meridian, an identical incision is placed exactly 180 degrees opposite. This produces symmetric flattening of that meridian, further reducing corneal astigmatism.
Astigmatism of plus 1.27 at 99 degrees. So the aim is to perform OCCI at 99 degrees. The 0 and 180 have been marked on a slit lamp, and they are just highlighted with the blue line to aid in ease of the rest of the markings. This is 100, and approximately this would be 90. So this is where the main incision would be, and this is where we anticipate to have the opposing clear corneal incision, again at approximately 99. We now demonstrate the creation of the opposing clear corneal incisions. It's very important that you check your keratome under the scope to make sure that there is no damage in the tip. So counter pressure, in this case afforded by a cotton bud, focus on the point that has been marked, define which is your starting entry point, and the surgeon now creates the main two-pointed incision by bisecting the 99 degrees so that the incision equally lies on either side of the marking. Now, the opposing clear corneal incision is now being created. I think it is a good idea to use some viscoelastic to form the chamber, because as I mentioned earlier, it is slightly challenging to create this incision, and you do not want to be left with a hypotonous eye, which might make the creation of this main incision slightly more challenging. So, whenever you need to make an incision inferiorly, pulling the eye upwards adds to the ease of the hole creation. So the surgeon makes the opposing clear corneal tunnel in this manner. It's just worth noting that the main incision here is what is going to be used for the phacoemulsification, and this opposing clear corneal incision is now going to be left undisturbed till the very end, wherein it's just going to be hydrated at the end of the surgery. Upon completion of the eyewear insertion as well as removal of the viscoelastic, the surgeon now, whilst maintaining the irrigation in the eye, moves to hydrating the incisions. As you can see, this is the main incision being hydrated. The left side port being hydrated. The source of the irrigation is out now. The right side port is now hydrated. And finally, we move to hydrating the incision that was created 180 degrees opposite the main incision. We conclude by ensuring that the main incision, the side port incisions, and the incision that was made diametrically opposite the main incision are well sealed.
While these incisional approaches laid the foundation for modern refractive surgery, the development of laser systems soon revolutionized the field, introducing precision, predictability, and safety. 2. Surface procedures. The next major category includes surface ablation procedures, which use laser energy directly on the anterior cornea after removing the epithelial layer. These are collectively known as photorefractive procedures. The most well-known is photorefractive keratectomy, or PRK. In this technique, the corneal epithelium is first removed, mechanically, chemically, or by laser, and then the excimer laser precisely reshapes the anterior stroma to correct the refractive error. Though recovery takes several days as the epithelium regenerates, PRK remains an excellent option for patients with thin corneas or those unsuitable for flat-based surgery.
This is Dr. George Waring from Charleston, South Carolina, and I'll be discussing photorefractive keratectomy, or PRK. Here you've seen we've applied a dilute alcohol solution which looses the epithelium from the underlying Bowman layer, and in an atraumatic fashion, we can simply use a wax cell to perform an epithelial rhexis, and you can see the sheen of the underlying Bowman layer. Now we'll have the patient fixate and apply the proper tracking with the excimer laser, and then apply the excimer laser. You can see the spherical correction here, now the cylindrical correction, and we'll then apply a mitomycin C 0.02% for 12 seconds, and then very vigorous irrigation and a bandaged soft contact lens. Thank you very much.
An evolution of this concept is transepithelial PRK, or TPRK. This advanced no-touch, single-step technique allows the excimer laser to remove both the epithelium and reshape the stroma in one continuous process. This minimizes handling, improves precision, and often results in faster epithelial healing.
Hi, this is Dr. Carl Stonecipher discussing transepithelial PRK as an option for refractive residual surprises. We use a PTK mode to remove at a 6.5mm optical zone, the 0.5mm transition zone, the epithelium. We enter in minus 0.66 refractive and a 70 micron component to the epithelial folder, and typically we're not taking off 70 microns. We usually take off somewhere between 58 and 64 microns with the epithelial removal. Following this, I wait 1 minute in foot pedal position 1, allowing the surface to dry prior to the refractive treatment. They're usually low refractive errors, and we laser the stroma without having any additional touching of the stroma itself in between the PTK mode and the actual laser mode. I do apply mitomycin C for 12 seconds. This is what I typically do in PRK, so I tend to do it in these patients as well. I copiously rinse the eye with 2 bottles of frozen BSS. And then following this, basically we'll place a bandaged contact lens, following the placement of non-steroidal anti-inflammatory drops, as well as a steroid and antibiotic. And that's pretty much the case in its entirety. Thank you.
LASEK, or laser-assisted subepithelial keratectomy, combines aspects of PRK and LASIK. Here, diluted alcohol is applied to loosen the corneal epithelium, which is lifted as a thin flap. The excimer laser then ablates the stroma beneath it, and the epithelial flap is repositioned afterward, offering faster recovery and less discomfort than traditional PRK.
Rationale of laser epithelial keratomileusis, or LASIK, surgery is to preserve corneal tissue, minimize ectasia, and avoid the flap-related complications of LASIK, while minimizing the incidence of pain and postoperative epithelial defects characteristic of PRK, essential in LASIK surgery. Attention should be paid to the drape and speculum and anesthetic drops in the fornix. Pre-placed epithelial marks are essential to allow repositioning of the epithelial flap at the conclusion of the procedure. Alcohol is then applied using a 7mm marker on the corneal surface. The marker has sharp edges similar to a trephine, and the pressure on the epithelium results in a shallow incision through epithelium, stopping at Bowman's layer. As alcohol covers the epithelium, the adhesion between the epithelium and Bowman's layer is weakened, allowing mechanical elevation of the epithelial sheet. The flap gutter is then dried. A modified jeweler's forceps is then used to dissect the flap edge, and a Maricel sponge can then be used to peel the epithelium in areas that do not elevate spontaneously. The use of a modified jeweler's forceps allows for easy separation of the epithelium from the underlying stroma along the margin of the trephination. In certain locations, this may not be easily done. We have, however, incorporated some modifications, such as the use of a modified Vannis scissors, to assist in creating a more even flap edge. The Maricel sponge is used to dry the Bowman surface, followed by excimer laser ablation. The treatment is centered on the pupil. The epithelial sheet is then carefully repositioned, and using a bed of BSS, it can be adjusted gradually until perfect edge alignment is achieved. The epithelial surface is allowed to dry prior to placement of a therapeutic soft contact lens. The contact lens can be gently tapped to ensure adequate adhesion of the epithelium. In summary, laser epithelial keratomileusis, LASIK, is a technique that may be an alternative to laser intrastromal keratomileusis, LASIK, especially in lower myopes and in patients who have predisposition to trauma.
A refinement of this approach is EpiLASIK, which avoids the use of alcohol altogether. Instead, a mechanical separator called an epikeratomy is used to gently lift a thin epithelial sheet. After stromal ablation, the epithelium is carefully replaced, promoting smoother healing and minimizing haze formation.
The epithelium is marked, just as in LASIK. The Moria EPK microkeratome is emplaced, being displaced slightly nasally with a 7.5 mm stop. Suction is obtained. Following this, gentile preservative-free drops are placed both on the separator and also on the cornea, allowing excellent lubrication. Position 2 of the foot pedal is engaged until the epithelium begins in the separator. Then position 1 is held for a few seconds, allowing the epithelium to enter the separator. Once this has begun, position 2 is re-entered on the foot pedal until the separator arrives at the EPK, the letter I in the EPK. From that portion forward, position 3 can be utilized, allowing the keratome to pass more quickly. This continues until the microkeratome engages the 7.5 mm stop. Low vacuum is engaged on the system. Additional gentile is placed on the separator and epithelium, and the reverse foot pedal is used to back off the keratome. Once the last of the epithelium has left the separator, suction is removed. The microkeratome is lifted from the eye, lifting nasally first to cause minimal displacement of the epithelial flap. As you can see, the flap is quite elegant, and now it's up to the surgeon to be gentle to the epithelium to cause minimal devitalization. A blunt spatula is used to accordion the epithelium back upon itself as atraumatically as possible. The surgeon, if he wishes, can check the corneal thickness remaining, and this epithelial flap was known to be just over 50 microns thick. Surgeons should take care now to dry the surface of Bowman's membrane, both with a wet cell and with a blunt spatula sweep. Laser application is then performed, and in this case, the physics S4 custom ablation was performed. Following laser ablation, it is advised to apply a frozen wet cell to the stromal bed for approximately 45 seconds. This is preferred over chilled BSS, and that the chilled BSS irrigating copiously over the epithelial flap will cause additional devitalization of epithelial cells. A small amount of BSS is in place across the stromal surface to allow adequate lubrication for sliding the epithelial flap back in position. This is used once again a blunt spatula, which should grasp the leading edge of the epithelium, gently repositioning the epithelium back into its original place. The central cornea is untouched during this part of the procedure. The other end of the spatula can then be used to bring forth any epithelium that might be underneath the flap on the edges. As you can see, there's only a approximately 1 mm overhang stretch. In this case, and in many cases, the epithelium fits back in position with no overhang whatsoever. A bandaged contact lens will be placed after 2 minutes of drying. This drying time is important for the epithelium to recede correctly. It's important to place the bandaged contact lens initially nasally and then draping it temporally so as to not once again disturb or displace the epithelial flap. Once again, everything that you can do as a surgeon to manipulate the epithelium less is vital for the patient's first 3-4 day post-op visual acuity.
Collectively, these surface procedures remain valuable options, especially for patients where corneal thickness or occupational factors make flap creation undesirable. 3. Intrastromal procedures. Moving deeper, the intrastromal procedures represent the next generation of corneal refractive surgery, combining the precision of femtosecond technology with the accuracy of excimer laser ablation. The most established of these is LASIK, or laser-assisted in situ keratomelusis. A corneal flap is created, traditionally using a microkeratom, or more precisely today, with a femtosecond laser. The flap is lifted to expose the underlying stroma, and an excimer laser reshapes the tissue based on the patient's refractive error. After treatment, the flap is repositioned without sutures, adhering naturally. LASIK offers rapid visual recovery and minimal discomfort, making it one of the most popular refractive procedures worldwide.
This is a brief video showing a mechanical microkeratome creating an SBK, sub-Bowman's keratomelusis flap, equivalent to that generated by a femtosecond laser. Moria's 1-use plus SBK disposable microkeratome is driven across the eye at a predefined speed and with perfect consistency. The corneal flap, which measures 99 microns, is lifted without the need to break adhesions. Underlying stromal bed is uniform and pristine. The bed is always dry and thus this step was not necessary. Higher magnification shows the even texture of the exposed stromal bed. Laser is applied and the flap rehydrated and put back into position. I like to float the flap in place and to use the generous markings to ensure an optimal fit. Bubbles can be seen in the interface. They are easily expressed. Surgery proceeds in a similar fashion for the other eye. Note the microkeratome's dial. This is set based on Moria's nomogram, which includes K readings and the desired hinge chord length. Again, the flap is atraumatically lifted, and the nearly perfect stromal surface is exposed. No drying is necessary. The laser is applied, and the flap put back into position.
This is Dr. George Wang. I'll be discussing femtosecond LASIK. Here we are docking the femtosecond laser and centering the LASIK flap over the entrance pupil. You can see a nice uniform LASIK flap created with minimal opaque bubble layer. Next, we'll be rotating the patient to the excimer laser, where we will use a spatula and gently separate the lamella, and we'll taco the LASIK flap. This is 110 microns intended flap thickness. Next, we'll ensure that the patient has properly tracked the laser tracking correctly. We'll apply the excimer laser. Here you can see the a spherical treatment, which is a moderate myope -5, and then a slight astigmatic treatment of a with the rule half a diopter treatment. Next, we'll use a small amount of BSS to gently reposition the flap, and then we'll irrigate with a very small amount of BSS also in the interface. We'll smooth the flap with wax cells.
Building upon this, FLEX, or femtosecond lenticule extraction, utilizes a femtosecond laser to create both a refractive lenticule and a corneal flap. Once the flap is lifted, the lenticule is manually extracted. This eliminates the need for an excimer laser while maintaining high precision. Femtosecond laser creates both a corneal flap and a refractive lenticule within the stroma. After lifting the flap, the lenticule is removed. It is considered an intermediate step between conventional femtoLASIK and the flapless SMILE procedure. The latest advancement in this category is SMILE, or small incision lenticule extraction. Unlike LASIK, SMILE does not involve creating a flap. Instead, a femtosecond laser sculpts a small refractive lenticule within the corneal stroma, which is then removed through a tiny side incision. This technique preserves corneal biomechanics, reduces dry eye risk, and provides excellent visual outcomes with faster recovery.
John Kalopoulos from Athens, Greece, clinical professor of ophthalmology at NYU Medical School, New York. We're going to see a fascinating case, femtosecond laser-assisted refractive lenticule extraction. You can see here the application of this magnificent device by Zeiss named VisionX, biplaning the patient's cornea, centering the visual axis. The patient is following the green blinking light, and now you saw suction coming on. The device is capturing the cornea, stepping on the pedal, creating first the inferior refractive incision, and then following that, starting reversely from center to periphery, the superior incision, anterior if you may, which as you see is wider, and then the SMILE vertical incision at the 12 o'clock position, 50 degrees in angle, from which we'll enter to remove the lenticule. After thorough training by the Zeiss team, and I thank you very much for that, I was able, this is one of my first cases, to go in with this disposable single-use spatula and find the space over the superior incision, and then go to my right here, which is obviously the patient's left side, and find the space, very important, inferior to the deeper inferior refractive incision. And you can see how the lenticule edge is seen over my spatula. Going in now with this olive tip reverse edge of this spatula and creating the superior to the anterior incision space. You can see the anterior incision is wider than the inferior, so I will try with gentle movements here to generate the space and definitely go peripheral to the inferior refractive incision. Make sure there's no tags remaining there. Now I'll enter the space that I generated initially under the deeper inner refractive incision, and I'll go all the way through to the inferior part of the refractive incision, find my way through the anterior incision here, and go gently from side to side. I do not want to free the refractive lenticule at any given side, because then I will have no traction to continue my removal. I'll leave the towards my incision adhesion of the cornea collagen tags left behind by the femtosecond laser assisted last. And now the lenticule is free. I'm removing it, and we're seeing the same process in the other eye. Final movements, and as you can see here, lenticule is out. I'm trying to avoid to use a second instrument, and what's impressive is the procedure's done. Patient has very, very low discomfort. This is the first postoperative day, very impressive result. Pristine cornea, a remarkable large optical zone. 2025 plus the first day, you can see the OCT image of the stromal interface. No vertical incision like in LASIK, a Gillian case. And thank you very much for your attention. This is John Kalopoulos signing out.
In this case, the gap is to 114 microns. We separate the front and back of the lenticule through incision. We dissect both planes starting with the front face. Once we dissect the lenticule includes a clamp and a strap.
For corneal implants beyond lasers, certain corneal procedures use implants to modify corneal curvature. Intracorneal ring segments, or ICRS, consist of small arc-shaped PMMA rings that are inserted into stromal tunnels in the mid-peripheral cornea. Their presence flattens the central cornea and regularizes its shape. ICRS are particularly useful for conditions like keratoconus or post-L ASIK ectasia, where corneal irregularity is the main problem rather than refractive error alone.
The interlaced femtosecond laser has already been used to create the corneal channels for the intact intrastromal segments. Small air bubbles in the cornea can be seen at the 2 o'clock and 7 o'clock positions in this view. A Y spatula is being used to widen and open the beginnings of the two segment
insertion areas. A deep corneal incision was also made by the femtosecond laser at 9 o'clock in this view. Here, a 450 micron intact segment is being placed in the inferior aspect of the cornea. The lamellar dissection with the femtosecond laser is done at approximately 65 to 75% depth. It's often tricky to get the intact segment all the way in because you're pushing it around a circle. Here it's almost all the way, sometimes the second instrument is used to push the end down. The near end is then pushed in a little bit further so it doesn't sit right next to the wound. Now the superior intact segment is being placed. Again, it's a little trickier to get the second one in compared to the first one because there's already space being taken up by the first intact segment. Here it's being pushed deep into the wound, and then once the channel is found, it can then be, ideally gently, but sometimes somewhat forcefully, rotated into its channel. Here it's moving nicely into the channel, and the second instrument is again being used to just give a little bit of pressure to kind of move it around the semicircular stromal incision that was made by the femtosecond laser. There the intact is popping into the wound, and then it'll be pushed in a little bit further so that it doesn't sit right next to the incision. Next, one suture is placed into the incision area to close that wound. It is tied, and then the knot is buried. I attempt to tie these knots fairly tightly so that the wound does not open up after surgery. These sutures are then usually removed about 6 weeks post-op. At the end of surgery, the intacts look beautiful. Here is a post-operative day 1 photograph, nicely sintered, well-placed implants.
5. Corneal shrinkage procedures. The final group under choroidal-refractive surgery uses controlled heat rather than mechanical or laser cutting to reshape the cornea. Thermal laser choroidoplasty, or TLK, applies holmium-YAG laser energy in a circular pattern around the periphery of the cornea. This heat induces localized collagen shrinkage, causing peripheral tightening and central corneal steepening, effectively treating mild hyperopia.
Unlike other refractive procedures that must be performed in a sterile environment, LTK can be safely performed in a doctor's examination room. A computer-controlled laser is focused on multiple points around the cornea. This area is outside the center of the cornea, where light rays enter the eye. The heat of the laser causes the peripheral cornea to tighten, making the central cornea steeper. As a result, light rays are then focused directly onto the retina.
Conductive choroidoplasty, or CK, achieves a similar effect using radiofrequency energy instead of laser. A fine probe delivers thermal energy in a circular pattern, shrinking stromal collagen and steepening the central cornea. It's commonly used for mild hyperopia, or presbyopia, providing quick and minimally invasive correction.
Who has the rounded speculum in the eye, I'm going to mark the cornea with a refractech marker. It has a series of 8 meridians marked with 3 hashes on each, and this will show us where we want to place the radiofrequency energy. So we're sending over the pupil, and you can see the 8 meridians. There's a mark at 6, 7, and 8 millimeters, letting the cornea, you want uniform hydration of the cornea. And then we'll dry a little bit. And at this point, we'll apply the radiofrequency energy through the insulated probe, which is 450 microns in length. It's depressed in the eye completely, and then the pulse of energy is applied, as you can see here. The placed in, and the energy is applied. You get a very small glaucoma, much smaller than that seen with laser thermal choroidoplasty. And what we do is we apply them first in the 6 millimeter zone, walking around. This is a side view showing the application. The patient feels absolutely nothing, just under topical anesthesia. Again, this is just showing you the tip, another spot being placed. As you can see, it's quite rapid. Again, treating another of the 6 millimeter spots, a little higher magnification. We check the tip each time to make sure there's no epithelial debris, so we get a complete application at the next spot. You can see you really want to press the cornea in a little bit, make sure it's fully in the cornea, and then apply the energy via the foot pedal. Here you go, press and apply. The length of application is preset at 0.6 seconds. Here we go, treating again, and you see the little white glaucoma. This is again a side view showing the application. And we treat each of the meridians, putting another spot at 7 millimeters. And this is in real time, so it is quite rapid and fast to do the procedure. A little bit higher magnification showing, you can see the little striae lines radiating in between. And again, the side view showing the application, a little bit higher magnification here. And that's it. There's 16 shots for a correction of 1.75.
Now, let's move deeper into the eye, to the lenticular refractive procedures, which modify or replace the natural crystalline lens. Phakic refractive lenses, or PRL, involve implanting a synthetic intraocular lens while keeping the natural crystalline lens intact. Depending on the design, these lenses can be placed in the anterior chamber, the posterior chamber, or attached to the iris. They are ideal for patients with high myopia or hyperopia who are not candidates for corneal refractive surgery.
In this video, Dr. George Lang implants the STAR ICL phakic intraocular lens. A clear corneal incision is made, the anterior chamber partially filled with viscoelastic, and the lens is then implanted via an injector into the anterior chamber. The ICL footplates are then positioned under the iris using a diamond-dusted lens manipulator, taking care to avoid exerting pressure on the crystalline lens in the process. With its 4 footplates under the iris, the lens is then fully secured in the ciliary sulcus.
In this video, insertion of the Verisize phakic intraocular lens is performed. The Verisize lens is a single-piece, 6mm PMMA lens manufactured by Abbott Medical Optics. It is a 8-chamber phakic IOL and is secured in place by Irish tapes. A 7mm square tunnel incision is required to place the lens. Foldable versions of the lens are available elsewhere in the world, though at this time, only the rigid PMMA version has been approved for use in the United States. A key step in the placement of this lens is the process of securing its clips to the iris, a process called encordation. As demonstrated here, the lens is placed essentially over the pupil. An encodation needle is then passed under the lens to catch a fold of the iris, which is then brought up through the iris clip, securing the lens into position. This process is repeated on both sides of the lens to ensure its proper fixation.
In contrast, refractive lens exchange, or RLE, also known as clear lens extraction, involves removing the eye's natural lens, even though it is not cataractous. It is replaced with an intraocular lens of appropriate power to correct high refractive errors. This procedure is particularly suited for older patients or those with extreme ametropia.
Implantation. The patient is a young lady of 20. She has been explained about all the pros and cons of clear lens extraction with intraocular lens implantation. Option of phakic IOL or given. Contact lens she doesn't want to continue anymore. Less is contraindicated in this case. So, after explaining all the pros and cons of phakic IOL and clear lens extraction, the patient opted for clear lens extraction and intraocular lens implantation. As started the surgery, the main incision has been made. One side also has been made on the left side of the main incision. Now, capsulorhexis. The capsulorhexis is being done with the help of digital forces. My plan is to take a rhexis of 5.5mm in diameter because the patient is dealing in this case fibrosis. The anti-capsular is likely to occur and there is a risk of capsular fibrosis. So I wanted to keep the size of the rhexis on the larger side of 5.5mm. Hydrosection has been done, very mild amount of hydrosection, and now same risk. So here goes the phaco proof, we get it down, and with 400mm of vacuum and 40 fluid, the lens mask is aspirated. I didn't want to try aspiration of optics with the phaco proof in this case. I want to employ a safer way because the patient is very young and the patient is highly myopic. This eye has myopia of -20 diopter. And the intraocular lens that I have selected in this case is 4.5 diopter plus 4.5 diopter. The optics is being cleaned. I have selected the Martis intraocular lens because the haptics support the equator of the capsular bags better. The haptics of the Martis intraocular lenses support the equator of the capsular bag much more, in a much better way than the single-piece intraocular lenses. The cartridge that I'm going to use will not go to the 2.8 mm wound, it's enlarged the wound to about 3.1 mm. Now here goes the cartridge, and the lens is, the leading haptic is going into the capsular bag. This is sensor Martis intraocular lens. And now this is the drilling haptic. It has gone over the iris. I tried to place the haptic in the bag, but it has gone in the surface. And now it is going to be difficult with the sensitive. If I had the side port on the right side, it would have been easier. When I use the main wound shape assessment, this white bush, you can place the haptic optic junction posteriorly in a much better way than the sensitive, and the drilling haptic has gone into the capsular bag. And now we have to clean the scope very nicely. In this case, we have explained to the patient that clear lens extraction and intraocular lens implantation will revolve off accommodative power. She will not be able to accommodate. What we suggested is either phakic IOL which she could not afford, and the complications of phakic IOL she didn't like. So we told her that we will keep this eye 1.5 diopter myopic, and she will be able to do most of the work without any specs. But for little vision, for distance as well as for near, she will have to use spectacle, either bifocal or progressive multifocal spectacle. So she opted for strict, probably progressive multifocal. She will take. However, explaining all the pros and cons of phakic IOL, the patient chose this option, clear lens extraction and intraocular lens implantation. However, we have explained to the patient that she has to undergo a regular follow-up for retinal examination. I have suggested 6 monthly retinal checkup to detect any peripheral retinal degeneration and retinal holes. And if it is detected, prophylactic treatment for the retinal holes. I have also explained to the patient about the signs and symptoms of retinal traction, floaters and flashes. And the patient was convinced that the clear lens extraction with intraocular lens implantation was a better option for her, considering the financial strength of the family. After cleaning the scope, the surgery is done. Check the integrity of the wounds, there should be any leakage, it is not there.